this session for the past 4 years, Tom, 4 or 5 years hasn't changed because it was the highest rated. For people like many of you that sometimes miss one of the meeting or actually really go to ASCO but do not go to any session during ASCO, ESMO, we spend it with other meetings. It's very important to remember what happened during these meetings. So we picked 4 major meetings where new data in general get presented: AACR, ASCO, ESMO, and ASCO GU, to highlight these. And we have 4 speakers. Tom, next.
Thanks, Tony. Tian, I think you're first. That's possible. AACR. When was AACR this year, Tony? When was it?
It was in the U.S.
I know it was. Well, when was it, Tony? When was it?
It was usually it's in the spring. You want me to be more specific?
Yeah, April. So the April AACR meeting. Tian,
April, yeah, before the World Cup.
And what we're going to do is, Tian's going to go. It's about how long you got? 5 minutes? 10-ish. 10-ish.
Yeah.
Okay, great. And then we're going to have a couple of questions, and then we're going to move on to the next session.
Okay.
Okay, great.
Very good. Thanks, everybody. Thanks, Tom and Tony, for having me and allowing me to try to summarize a really large meeting in 10 or less minutes. So I'll give you my take on what I'm thinking about as I approach AACR highlights as a clinician, as a trialist. Here are my disclosures. The ones in blue have approved therapies in kidney cancer. So we'll talk a little bit, about resistance and how we're thinking about targeting HIF-1 beta or ARNT, also immunotherapy checkpoint resistance, and some of the trials that read out at AACR around targeting CCR8 and TGF beta. Give you a glimpse of what we're doing on spatial profiling, and then talk about Monty's gut microbiome data as well. So you all are very familiar with the expanding landscape of treatments approved in kidney cancer. I would highlight that in the last 5 years, we've had multiple approvals now in HIF-2 alpha inhibition with belzutifan, both for VHL syndrome as well as refractory kidney cancers. And then most recently last month, the approval of belzutifan in combination with pembrolizumab for adjuvant treatment of kidney cancer. But when we are having all of these immunotherapy doublets and now HIF-2 alpha inhibitors, we have to think in our clinics about resistance and what happens when our patients are progressing on these treatments. So a glimpse of what I think were important at AACR was a look at considering these mechanisms of resistance. So I'll just remind this audience that targeting the HIF complex is actually quite challenging, and up to a couple years ago, we didn't think this was possible. But in normal oxygen conditions, as we know, the HIF complex gets degraded via VHL as a E3 ligase, ubiquitination, and targeting for the proteasome. In hypoxia conditions or without VHL, the HIF complex is allowed to build up, translocate, and then go and have the downstream transcription. And so at UT Southwestern, we're very proud of the fact that the small molecule targeting HIF-2 alpha was actually discovered on campus. And here you're seeing PT2385, one of the first molecules intercalating at the PAS-B domain, that intersection between HIF-2 alpha and HIF-1 beta, or the aryl hydrocarbon receptor nuclear translocator. Say that 5 times fast. And so this is a really important complex, and the understanding here of the biochemistry is very important because it's a clue as to the resistance mechanisms that happens at this dimerization domain. There's also a clue that HIF-2 expression is very important in metastatic disease, as well as in some of the cohorts that we're not targeting in optic RCC. So this comes from Brian Reeney's talk at AACR, where he's showing, and Scott Hake was seminal in doing this work, that there's more HIF-2 expression in metastatic disease, as well as in those clusters that we're actually not treating in optic RCC, the excluded clusters, so they're not angio, and they're also not pure IO. Jim Brugolis' lab has been really one of the first to show the acquired resistance to HIF-2 alpha inhibitors. And so this came from the phase 1 paper that read out several years ago now, that there are HIF-1 beta mutations at the 446 stop, and also HIF-2 alpha mutations at G323 that both confer resistance to these peloton molecules. And so both of these are at that PAS-B domain that I just told you was so important in that dimerization process. And so when these sites are mutated, it confers resistance. So what do we see at AACR? We saw some interesting information about the ARNT and also ARNT2, that indeed if you knock down ARNT2, which is very specific for neural and kidney tissues, but not ARNT, that resistance increases to belzutifan. And also if you overexpress ARNT2 but not ARNT, we can improve some of the belzutifan sensitivity in VHL deficient cell lines. And why this is very important is now we are seeing some preclinical data of some proteasome degraders. So NEO-811 is the first, I think, that we've seen in the public domain looking at this molecular glue. So it's actually functioning kind of like VHL, but it's making it's pulling the HIF-1 beta particle over to the proteasome, allowing it to be ubiquitinated and targeting for proteasome degradation. And so if you look at the xenograft curves, there's efficacy in 7860 tumor xenografts, and also in the 7860 HIF-2 resistant cell lines with that G323E mutation, this particular compound is also active in suppressing tumor growth. So I think much more to come of this molecule and other molecules for HIF-1 beta degraders in the years ahead, but this is one of the leading molecules. All right, we'll turn our attention a little bit to immune checkpoint resistance and think a little bit about some of the immunotherapy resistant disease and phase 1s that read out at AACR. This one is an agent targeting CCR8. Many of us in the room have been following the CCR8 story to target regulatory T cells. This one in particular is called Dana-Farber in IO-resistant disease, and you're seeing in about 57 patients treated on this phase 1 trial that this monotherapy is active at doses over 10 milligrams every 3 weeks, and there was about 8% objective response rate, particularly for IO refractory disease. This next one that I'll show you is inhibiting integrins. So a compound called PLN-101095 is inhibiting integrins and blocking TGF-beta and trying to improve the immune sensitivity in IO-resistant disease. So this phase 1 also accrued both for monotherapy as well as combined with pembrolizumab, and there were actually a few kidney cancers in this cohort that also responded. All right, what did our lab show at AACR? We've been thinking about spatial profiling with pre and post IO treated biopsies and nephrectomies, and thinking through what might come up as targetable proteins. So I'm sorry, this is not the most recent slide, but what you're seeing on that plot there is the upregulation of Nectin-4, the usual suspects of AXL and MET, but there's also TROP2 and very interesting targets that I'm sure sound very familiar to all of you. So considering how we might target these in IO refractory populations in the future, I think is one of the key sequential questions that we need to answer for our field. And then finally, I want to highlight Monty's work. This work comes out of City of Hope, thinking through gut microbiome. There's our 2 phase 1s, as you all are well familiar with, treating patients with ipilimumab and nivolumab with the addition of CBM-588. They did some nice correlative work on these studies, modulating T-cell exhaustion. And so what they're showing is comparing the correlative samples from patients treated with CBM-588 588 in combination with ipi/nivo versus ipi/nivo alone, that those T-cell exhaustion populations goes down, and so there are more activated T-cells for patients that are treated with the CVM 588 probiotic. And of course, you heard this morning, but this sets up very nicely the ongoing SWOG trial called BioFront that opened this year. This is led by our friends Pedro Barada, Monty Pal, and Elka Vashampayan. So if there are any patients that are thinking about, how do I modulate my gut microbiome? This is the trial to sign up for. So immunotherapy doublet as standard of care with CBM 588 or placebo. And I think we should all get behind it and try to help our friends enroll the trial and learn about whether this probiotic might be helpful in conferring IO sensitivity. And this is the last content slide that I have, and I wanted to highlight some of the AACR plenary themes and how they might apply to our kidney cancer field. So there were 4 plenary themes that were big splashes at AACR. Next frontier in minimal residual disease. Well, gosh, we saw some really cool data of circulating tumor DNA out of the Keynote 564 analysis. I'm sure Dr. Surzin is going to highlight that next in his ASCO update. The next one is on precision partnership and purpose to save lives globally, and we can all get behind this one, that our targeted therapies, whether they're immunotherapies, HIF2 alpha inhibitors, that we want to make these targeted therapies available for all patients all over the world with kidney cancer. The third one, AI revolution in cancer research. I think we'd have to be living under a rock not to think about AI and how it might change our world and how our research. And so thinking about using AI in smart and efficient ways are going to help us support clinical decision making and our research going forward. And then the last is cellular therapies coming to solid tumors, and I very much hope this is the case, and we're waiting that next wave of CAR Ts and CAR NK cells to impact kidney cancer. Perhaps we take a page out of melanoma and also learn from the TIL therapies. Maybe we can recreate those in kidney cancer. And with that, I will thank you all very much for your attention.
Okay, great. Next, we're going to have Mike Surzin from Dana-Farber. Actually, Mike is in charge of most of our summaries post-meeting with our internal meetings, so maybe using the same slide, I don't know, Mike. But ASCO was quite interesting, and let's see, Mike.
Yeah, so I think it was a quote that's attributed to Chuck Drake. If you want to know where you want to be where the puck is going, and I think for me, the best way to know where the puck is going to be is to know where the puck has been. And so I think what I'd like to do is take a deep dive into some of the data that we saw from the ASCO annual meeting this year. First, we're going to talk about radical. Was that the beginning or the end of radioligand therapy? As Tien mentioned, we're going to talk a little bit about some of the adjuvant data that we saw in kidney cancer. And then lastly, a really innovative way of trying to understand what impact immunotherapy is having for our patients who are treated with adjuvant immunotherapy. So again, first, we're going to go over the radical study. This was an Alliance Cooperative Group study presented by Dr. Raina McKay. And we know that patients who have kidney cancer with bone metastasis, this portends a poor prognosis and a high burden of comorbidity as the disease goes along. There was initially a pilot study run by Dr. McKay when she was at Dana-Farber showing that we could combine radium, so a radioligand therapy that mimics calcium and emits an alpha radiation, could be combined with a VEGF TKI therapy with sunitinib or pazopanib. We also know that cabozantinib, one of our standard VEGF TKI therapies, has activity in bone, and so that was really the rationale behind launching this phase 2 study combining radium with cabozantinib. And to remind folks, this was patients who could have any RCC histology. They could have received prior TKI therapy, however, they could not have received, they could have up to one untreated bone metastasis, KPS greater than 60%, and patients were randomized to either cabozantinib plus radium given once IV every 28 days for up to 6 cycles, or cabozantinib at its approved dose. The primary endpoint of this study was looking at symptomatic skeletal event-free survival. And what we know from the patients who enrolled on the study was a majority of them had clear cell kidney cancer, so 80%. About 20% of patients had non-clear cell. 20% of patients had liver metastases, and 60% of patients had had a prior symptomatic skeletal event before enrolling on study. We know a majority of patients got 5 or 6 cycles of radium. The median dose of cabozantinib was different in the arm. So on arm A, we saw the median dose was 30 milligrams of cabozantinib versus 40 milligrams in the monotherapy group. Unfortunately, Radical did not meet its primary endpoint with no improvement in symptomatic skeletal event-free survival, but I'll call your attention to a very interesting trend that we saw on those curves. We did see a crossing of those curves and perhaps a delayed separation favoring radium plus cabozantinib as time went on. There was no difference in PFS between the treatment arms, with a median PFS of about 10 months with the combination or with monotherapy. And again, when we look at overall survival, we see this interesting flipping of the curves that happens at about 10 months, again, with perhaps a delayed separation as time goes on. Things that I've thought about is who are those patients at the tails of those SSE and OS curves? You could think of a couple hypotheses, but perhaps those patients who progressed early had a high burden of extra-osseous metastatic disease, perhaps a high burden of osseous disease, or a prior SSE, and perhaps those at the tail of the curve had bone-only disease or a lower burden of bone metastases, perhaps no prior symptomatic skeletal events. Again, hypothesis generating for me. We saw the combination was relatively well tolerated. There were increased rates of cytopenias with the radium, but mostly grade 1, grade 2, perhaps higher rates of TKI toxicities in the monotherapy arm. So again, I think that this was a really innovative study ahead of its time. It was the first randomized trial to use a radioligand therapy in RCC, the first site-specific study, and I think really speaks to the innovation that we can do in investigator-initiated trials, as well as the collaborative effort of cooperative group studies. This 98 patients were enrolled across 28 sites, again, proving we can do this work. How does this inform future trials? Well, again, I think theranostics may help guide treatment selection for who's optimally primed to respond to a radioligand therapy. We've heard a number of studies that new targets, new radiation particles may be able to help move this field forward, and then really asking the question, what is the optimal partner for radioligand therapy? Is it IO, is it VEGF TKI or HIF, and in what setting are these optimally going to make a difference? I will highlight a trial in progress poster with that Monty Powell is leading, was also a trial in poster, I believe here at KCRS as well, using a CA9 radioligand with lutetium as a beta emitter, and they're enrolling in 2 parts, so dose optimization, and then eventually moving to a randomized phase 3 study in refractory clear cell kidney cancer. And again, I think that this is just the beginning of radiopharmaceuticals for kidney cancer. So again, we have multiple studies being led by folks in this room, not only targeting CA9, but also PSMA, again, with different in different treatment settings and with different radiation particles. So moving on to the adjuvant setting, where we saw some really exciting data from both the Rampart study and ctDNA in MRD. First, I'll go through the data that we saw from the Rampart study. And to remind folks, Rampart was a large randomized phase 3 trial led out of the UK, initially designed as a 1,700 patient trial for patients with kidney cancer who had intermediate or high risk by Leibovitz score, randomized in a 3-2-2 fashion to active monitoring, a year of the PD-L1 inhibitor durvalumab, or a year of durvalumab plus 2 doses of the CTLA inhibitor tremelimumab. Again, I highlight the inclusion criteria a little bit different than Keynote 564, with relying on TNM as well as nuclear grade and the presence of necrosis. Vast majority of patients on Rampart were clear cell. Again, maybe 15% of patients had non-clear cell disease. Only 5% of patients had M1 NED disease. And we had seen the previous data that Durva plus Tremi relative to active monitoring did improve disease-free survival. However, the data that we saw at ASCO this year showed that the durvalumab alone arm did not improve DFS relative to active surveillance, you see hazard ratio of 0.74. Now, when we saw the data, the DFS benefit in Durva plus Tremi, we saw that that was enriched in patients who had Leibovitch high risk. We did not see that same trend in the durvalumab monotherapy arm. Unfortunately, neither of these arms improved overall survival. Again, excellent 3-year OS rates, all greater than 96% on this study. So what are our takeaways? Again, unfortunately, PD-L1 did not improve outcomes in this study. And how does this help us moving forward? Well, I heard it uttered yesterday, and I think it's worth echoing the point. I worry that in the adjuvant setting, TNM and our current risk models may be holding us back, and that I'm hopeful that using more tissue-based or hopefully circulating biomarkers can not only help us understand who are those patients who are at highest risk of recurrence after their surgery, but also who is primed to potentially respond to an immune-based therapy in the adjuvant setting. I'll highlight a poster at ASCO that looked at one of those emerging tissue-based biomarkers. This was looking at H&E slides from the Checkmate 914 study. This was, as many know, the adjuvant study of Nivo or Nivo plus Ipi as adjuvant therapy. And what they did was they looked at, again, 1,000 patients, did H&E, and classified patients by vessel branching patterns, whether they were high branching or low branching, and then looked at outcomes on study. And what they showed was very nicely, if you look at the middle plot, that patients who had the highest branching pattern had the best disease-free and overall survival. And then you see a very nice separation by the quartiles of vessel branching patterns. So again, and then on the bottom, they did a C-index modeling, and they compared TNM versus vessel branching pattern versus the combination, and they found that the branching pattern plus TNM had the strongest prognostic performance. So the next data that we'll go through is the ctDNA analysis from Keynote 564. This was data that was presented by Toni. And again, we know 564 improved DFS, OS. Now Pembro is our standard of care for adjuvant clear cell kidney cancer. We know that 75% of patients on study were ctDNA evaluable. I think this is one of the largest data sets of ctDNA in kidney cancer that I'm aware of. And unfortunately, these exome-based ctDNA had very low sensitivity after surgery. You see only about 5 to 8% of patients were ctDNA positive after surgery. Perhaps we see an enrichment of that ctDNA positivity when we look at intermediate and high risk, but again, very small numbers, so I'll caution to not draw too many conclusions from that. Well, what does it mean if a patient was ctDNA positive? Well, we know that that portended a poor prognosis, and again, this is probably not all that surprising to us, whether that was detected by a 16 or a 64-plex assay. And perhaps reassuringly, we saw that ctDNA clearance at cycle 5, day 1 was higher in the Pembro arm at 50 to 60% relative to placebo. And then on the right-hand side, we see ctDNA dynamics matter. So those patients who were negative to begin with and stayed negative, they had the best prognosis and best DFS. However, those who were positive and stayed positive, they had the worst prognosis. And I'll call your attention to the right-hand side where 9 out of the 25 patients who were ctDNA positive on the placebo arm actually cleared their ctDNA, which again is kind of a head scratcher, and I think we need to better understand why the assay performed in this way. And for me, when I treat patients, I think it's tough to know what to do with that result for a patient because of this. So again, unfortunately, exome-based ctDNA does have low sensitivity. We know Pembro does clear ctDNA more than perhaps placebo did. How does this inform us going forward? Well, again, I think that there's room for improvement here. There's new technologies coming our way that I think are primed to make a difference. So whole genome, exome-based ctDNA will hopefully improve that sensitivity. And then also thinking about learning from the folks in bladder cancer, where we know ctDNA is probably not a binary positive or negative, but there's also degrees of positivity and degrees of, and the dynamics of turning positive early versus turning positive late, those probably make a difference. I think that this is a strategy that's hopefully going to help us to both intensify therapy and de-intensify therapy in the adjuvant setting. The last couple minutes, I'll go through a really fascinating look at decision regret and patient-defined toxicity for patients who received adjuvant immunotherapy for kidney cancer. This was work led out of the UK, mentored by Dr. Powles and led by Elizabeth Nally. And while I alluded to that Pembro is our standard of care in the adjuvant setting, we know that there are certain toxicities, immune-mediated, that do have a long-term impact on our patients. And yet, despite that, when we look at all of our adjuvant immunotherapy trials, there's this common line that comes out that says no clinically significant meaningful change in health-related quality of life from baseline. And yet in the clinic, we know that these immune therapy toxicities can have a long-term impact for our patients. So when we see this result, we're reassured, but we actually worry, are we not capturing the patient's experience? So what the group did was they came up with a patient-derived toxicity framework, and then they tested that in a retrospective analysis of patients treated with adjuvant atezo on the Emotion O&O study. And they broadly defined 4 different toxicity groups. So there were life-changing toxicities. We think about things like endocrinopathies, cardiopulmonary neurologic toxicities, significant short and significant long-term toxicities, and then patients who had no significant toxicities. And patients who got adjuvant atezo, about half of them had no significant toxicities, a third of patients had significant, and 12% of patients had life-changing toxicities. When they reclassified CTCAE grade adverse events by these patient-defined toxicity groups, reassuringly, those patients who had the highest toxicity, so grade 3, grade 4, 87% of them were reclassified as a significant or life-changing toxicity. That makes sense to me. What doesn't make quite as much sense is patients who had grade 1, grade 2 toxicity, a third of them were actually upgraded to life-changing or significant toxicity. Again, telling us CTCAE grade toxicity is not fully capturing the impact that these are having on our patients' lives. They did a number of health-related quality of life assessments on Emotion O&O, both on treatment, post-treatment, and in follow-up, as shown here. And it was the FKSI 19 measure that was done. And again, reassuringly, when they looked at health-related quality of life on atezo versus placebo, they see no difference in health-related quality of life. But then for patients who received adjuvant atezolizumab and had a grade 3/4 adverse event, you see a slight trend towards decreased health-related quality of life relative to those who had grade 1/2 toxicities, but that goes away over time. And again, I bring up FKSI 19 here on the right just to bring you up to speed on what we're asking patients in these measures. There are some questions about the presence of pain, bone pain, fevers, and blood in the urine. Again, asking, are these the right questions to be asking patients who have no evidence of disease, and is that capturing the impact that a long-term immune therapy toxicity is having for our patients? The last couple slides I'll go through, this was the completion rate of those health-related quality of life assessments. So in green, you'll see those are patients who had no significant toxicity, and not surprising, throughout their treatment and after treatment, those patients were completing their questionnaires and had good scores. Whereas those patients who had life-changing toxicities in red, they often came off study, and therefore their rate of completion of these health-related quality of life assessments went down. And bringing up the question for me, are we undersampling those patients for which the treatment is having the most impact on their health-related quality of life? The last 2 slides I'll go through, I think this is a super important slide in that it shows those patients who had a life-changing toxicity had a sustained decrease in their health-related quality of life even after they came off therapy, whereas those patients who had grade 1, grade 2 toxicity, it doesn't tell that full story on what effect it has on their long-term toxicity. The last part of this is they did look at decision regret. So they asked patients, did you regret the decision to go on adjuvant immunotherapy? And it was those patients who had life-changing or significant toxicities who had the highest regret scores, not necessarily those who had grade 3/4 adverse events or recurrence of their disease. So how do I use this in the clinic? Well, again, I think I often do quote these numbers now. I don't just say what the grade 3/4 adverse events are. I say there is a 10% risk of life-changing toxicity, and I think we really ought to be incorporating more of these into our adjuvant studies. So I think I'm over time, so I won't do a summary slide, but I appreciate all your attention, and I'm happy to answer any questions.
Great, fabulous, fabulous. Laurence, come and join us. ESMO, European representation, European meeting, fabulous. Toni, while Laurence is getting ready, quick question for you, if I may. we have heard some radioligand data yesterday which didn't look great, and then we've seen some more data with radioligands today which doesn't look great. Should we stop investigating radioligands in kidney cancer?
Where did that come from? But yeah, no, I mean, yes, we've seen the data from our center where 11 patients treated with Pluvicto, lutetium PSMA, none achieved a response. I do think we should continue. I mean, we have to look at other target first. The PSMA is on the vasculature, and what's the payload? If it's resistant, can we go up the dose, etc.? There are other things that are coming down the line. So that's my 2 cents.
And give me so if PSMA doesn't work and radium-223 doesn't work, these are the two, blockbusters in prostate cancer. We need a miracle, don't we? What was the target?
No, we need something that are more specific to kidney cancer.
Have we not got better things to do with our time and our money?
No, we need to cure patients, CD70, CA9. I think the problem may be radiation itself with that, if you want, payload, but there are other things coming, like the one with Dr. McKay. Renal?
Do you want to say something? You take this microphone.
I want to rebuttal that. I would say that we just need an appropriate target, and I think actually when you look at the way Radical was designed, and us basically not having negative criteria for people enrolling, the OS curves for Radical actually mirror exactly what was seen in Piece 3, where there's an initial decrement, probably because of people falling off. I do agree with Mike about that, because we did not, if you had one bone lesion, you were allowed to enroll. But then there's a tail in the curve, and we're looking at patterns of progression for these patients. So I think it's, and the PSMA story I think is different because it's not a tumor-specific marker. We've seen the data that's been presented in case report that basically the tracer, the drug, is being washed out of the tumor. So I think you need a good target. We saw the data from Michael Hoffman that he presented last year with CA9 targeting, which I think has a lot of legs.
Great. So, Laurence?
Sure. So thanks again to the organizing committee for the opportunity to review ESMO highlights. So we're traveling in space. We're going to Germany. We're traveling in time because this meeting actually happened before the two we just mentioned. We're in October 2025. And so we had 2 main results in the localized setting. The first one being the first presentation of RAMPART, the second being a neoadjuvant study. So RAMPART has been presented by Michael. I'm going to just highlight the fact that the first presentation reported only in one of the 2 arms, experimental arm, which was the combination arm. You already saw the data with regard to the patient population. Bear in mind that these were allocated based on the Leibovitch criteria, and about half of the patients were high Leibovitch criteria. That overall the study showed this signal in terms of disease-free survival, favoring the combination arm of durvalumab plus tremelimumab. But what was very interesting is that the magnitude of benefit was actually triggered or pulled by the higher risk patient population. So the study confirmed not only the role of IO in the adjuvant space, but the fact that it's based on how we define our patient selection. And so these are the DFS data in the higher risk patient population using Leibovitch criteria, and this is the DFS in the intermediate risk. So that is feeding our discussion on how we select adjuvant, who should be the patient receiving adjuvant. And so in RAMPART, what we're seeing is that combination therapy has a role in patient that has a very high risk of relapse. With regard to toxicity, as one can expect, the fact that we're having durvalumab plus tremelimumab being a CTLA-4 component here is associated with high-grade toxicity, this 40% of grade 3 adverse events, and about a third of the patient that required steroid in the experimental arm. So the conclusion is that, yes, adjuvant therapy with durva and tremi was associated with an improvement in disease-free survival that was obviously driven by the higher risk patient population, and that the toxicity we saw was of course related to the CTLA-4 addition. And then you heard on the next round of data that was presented afterwards. Now, switching gears to the neoadjuvant, I really want to say kudos to Axel, who is in the room, and John Hannon and the NKI team for conducting NESCIO. This is a platform neoadjuvant study where they investigated single-agent Nivo, Nivo-EP, and Rela plus Nivo. I think this is extremely well-designed study, very well conducted in the Netherlands. What is interesting in this cohort is that ultimately, are we able to properly define the right endpoint in the neoadjuvant space? We want to cure more patients, so we would like to expand disease-free survival and overall survival, but what we'll be looking at is pathological response. And so in the study, they decided to define the pathological response a bit in line with what has been done in melanoma, looking the degree, the magnitude of benefit. So we see that in the experimental arm of nivolumab plus imilab, as well as in Rela-Nivo arm, we had patients achieving either near complete response or one partial response. We're not seeing major complete response across border here, but we're seeing activity. And the second take-home message of this study is that when a patient achieved significant pathological response, the patients are less likely to have further disease progression. So to some extent, a surrogate of long-term benefit. So this is food for thought. It's important that we have a very well-organized structure of our neoadjuvant trials platform, and this is exactly what Grant Stewart, Axel are building across Europe. Now, switching to metastatic, I've decided to address 3 different blocks: first-line setting, second-line plus, and a bit of biomarker. So first-line setting, Cristina Suarez presented the Keymaker Umbrella 03A study. That was a concomitant publication in Annals of Oncology. You're all familiar with this multi-arm phase 1 study that was exploring different combinations. What was interesting here is to think about the rationale of moving towards triplets. And you know that this is what has been taken to a larger scale in the O12 study that I'll be mentioning at the end of my talk. What we're seeing here in this table that I try to summarize is that to the right part of the table, you see the reference arm, pembrolizumab, as one of our standard of care in first line. The addition of either CTLA-4 or belzutifan is associated with a high response rate. Progression-free survival is being expanded in the LAG-3 as well as in the belzutifan combination on top of these two. And with regard to overall survival, we see a signal that seems to be across the border in the LAG-3 and the belzutifan combination arms. So that confirms the assumption that the combination triplets we would like to have at a larger scale are the one with either the CTLA-4. And when looking at these curves, one could ask, is there really a signal when compared to the reference arm? Or the addition of belzutifan on top of pembrolizumab and lenvatinib, as you know, the third arm of the O12 study. So important piece of data, phase 1, taken to the next level in the O12 study. Another study that really catch our eyes was the first presentation of the OPTIC trial. So a very important study in the way, this is a SMART study, and congratulations to the investigator. It was presented by Scott Hake. And so built on the Emotion 151 RNA data, this phase 2 is building on the fact that the allocation of a specific treatment in first-line setting, depending on the RNA-seq data, would help to reach a high response rate. So it's a proof of concept. The primary endpoint is response rate, and the assumption is that if you allocate IO-TKI in those patients that are angiogenic driven, your response rate should be above 75%. So that was the goal of this first report. Bear in mind that, of course, you need to cluster the patient, so you need to have the information on which cluster is your patient and then allocate the treatment, and what was reported here were only the angiogenic driven profile. Long story short, 100 patients screened at that time, about a quarter that were allocated to the angio cluster. Second information, you don't have the same profile if you look at the primary biopsy or if you look at the metastatic biopsy. And I think this is very important when we inform our practice, because that led the investigator to amend the protocol in a way that they were requiring biopsy of the metastatic site. Ultimately, the study reached its endpoint because the response rate among those 25 patients that were angiogenic clustered was 76%. So yes, in angiogenic-driven tumors, Cabo-Nivo is doing great, and this is the depth of response that was seen in this trial. So I think what is interesting, it's a tissue-based RNA-seq biomarker trial. Bear in mind that you need to think twice about which tissue you're using to define your gene expression signatures. And that, of course, highlights the fact that if your patient is angiogenic-driven, an IO-TKI combination makes sense in response rate. But we don't have long-term follow-up, we don't have PFS, and it's not randomized. Now, moving on to non-clear cell, you're all familiar with Sunny Forecast trial that investigated academic trial Nivo-EP in non-clear cell patients. That's a subset of Sunny Forecast that was represented because first presentation occurred a year before at ESMO. And here, what was reported were the chromophobe patients. So it's only about 50-ish patients, almost 60. But it's interesting because we have very few randomized data per each subtype, and these are the chromophobe patients. The key message to me is that big picture, you don't see much of a difference between experimental arm, nivolumab, ipilimumab, and standard of care, which in the trial was physician decision, which could be TKI single agent or IO-TKI. It was mostly TKI single agent. And what is interesting here is that CPS seems to be the factor that could potentially help you to define your IO-IO strategy in chromophobe patient. So for a long time, we say chromophobe, they're not driven, we shouldn't consider IO. We have another study here with combination of IO, nivolumab, ipilimumab, in CPS positive patients that seems to be associated with long overall survival. Now, I want to switch to second line plus setting. So LEN-CABO is a study that was conducted in the US, as well concomitant publication in Annals of Oncology. It's a very straightforward trial. Patients had to have prior exposure to PD-1 or PD-L1 inhibition, 1 or 2 lines of treatment, and were randomized to 2 of our standard of care in second line plus setting, Len-Ev or cabozantinib standard dose. 3 centers in the US. I would say 2/3 of the patient only had 1 prior line of therapy, and you see in the bottom the different treatment regimen, either IO-IO or IO-TKI that were previously exposed. Study demonstrated the PFS difference in favor of the Len-Ev, reaching about 16 months versus 10. With regard to response rate, we also have a trend favoring the Len-Ev arm, but you can also see that cabozantinib derives great benefit in this patient population, and no difference in terms of overall survival. That's a small study, that's a practice-informing study, and I think it's good to see how our different standard of care in second line or third line setting are performing in, I'm gonna say, almost real-world data. Now, I'm gonna finish on the biomarker. I selected 2 pieces. So we heard throughout the meeting the growing role of KIM-1. I think the analysis of KIM-1 in COSMIC-313 reported by Vincent was very important. Why is that? Because we're in the metastatic setting. What was demonstrated here is that we have high level of KIM-1 in metastatic setting. Nothing compares to what James Jones presented yesterday, about 180 you're seeing in adjuvant to define on your threshold. Here it's 6,000, okay, so very high level, associated with your IMDC risk group, associated with your tumor burden. So there is a clear association between the baseline sum of target lesions and the level of KIM-1. So it's a good surrogate of your metastatic burden. As we are seeing across the study, high baseline is associated with worse overall survival, given it's associated with tumor burden. And interestingly, the association of a KIM-1 drop at a specific time point, which was 7 weeks, for the IO-IO only arm, because we're in COSMIC-313, was informative of the outcome. So I think this is interesting. It's not the same for IO-TKI, but for doublet IO, this is potentially a cutoff mark where you could look at and have some estimation of your outcome. The second piece of biomarker, we're back to the microbiota, and that is the soluble MADCAM. These data were presented by Mark Mascialani. It's a joint effort between Dana-Farber and Gustave Roussy. And so MADCAM is a blood-based biomarker that could serve as a surrogate of the gut dysbiosis. And so why is it important to highlight that? First, it's a massive academic effort using 3 different clinical trials, The Javelin data had been presented in the past, and these are two independent, large prospective studies, single-agent TKI or single-agent PD-1. Across the different trials, what we're seeing is that high level of MADCAM is associated with overall survival, so it's a prognostic biomarker, and this has been validated in two independent cohorts. And why is it interesting? Because MADCAM is actually associated with distinct inflammatory microbiota composition. So we have different species that are associated with different level of MADCAMs. And so it means that, A, we have a circulating biomarker that can be prognostic. Second, that this dysbiosis could define if there is an immune dysregulation. And third, that you want to have a specific target microbiota intervention, and that feeds into the discussion we were having around the trial that is now open in the US. And so that data was subsequently published in Nature Medicine. So because I'm right on time, and because I'm closer to ESMO 2026 than 2025, yesterday I went online. I say, I can't disclose anything that is not available, but this is online. So if you go online, you'll see that on Sunday, and I don't have the date, Sunday 25th, we'll be all together for the ESMO GU a non-prostate track, and this is the oral presentation, and I want to draw your attention to three different presentations we'll have. The first one will be LightSpark 012, so feeding back to Christina Suarez's umbrella presentation. So Toni will be presenting the results of this important phase 3, trying to challenge lenvatinib pembrolizumab. Many of you know that there has been a press release, and so we are eagerly waiting to see the data of the performance of the three arms. Second is in second line setting plus, so LightSpark 011, Bel plus Len versus cabozantinib. We know the PFS data, but we want to have the final analysis, and Dani will be presenting this final analysis. And third, but not least, it will be the phase 1 results of the XmAb 819. That's a novel ENPP3 CD3 bispecific. So ENPP3 is differentially expressed target with a high level of expression on kidney cancer cells, so renal cell carcinoma cells, both clear cell and papillary, by the way, highly expressed when compared to normal tissue. And so there has been different drugs that are being developed targeting this, but the XmAb 819 is a bispecific T-cell engager that is targeting ENPP3 with two ENPP3 domain. And so we are eagerly waiting to hear from Monty about this phase 1. And I'm going to stop there, and thank you very much for your attention.
Thank you. Should we do, Katie, then take all the questions? Or I have a question for you.
Far away.
So my question for you, since you asked me a question, I want you to tell us all, since you've been involved, what do you think about Rampart? It's a positive study for, CTLA-4, PD-L1, and there's a lot of people here, one of them looking at me directly here, and I'm looking on that love CTLA-4. So,
I think the Rampart trial is a bit of a fruit salad of a trial, because there are lots of arms and there are lots of results, and they can be interpreted many different ways. The trial mixes clear cell and non-clear cell patients, and actually that's quite an important distinction, because if you look at the subset of the clear cell population, the two arms look identical to each other. The hazard ratio is identical for both arms, durva-tremi and durva. I think there is discussion about high risk and intermediate risk, but actually when you look at the patient population that went into this trial, it was a better risk overall than 564. It's a different group from 564. They're not directly comparable. And then the last thing about the trial, well, it was an open label study. It was underpowered. It closed a bit early. It was conducted during COVID, and some of the patients came off study. There was no central radiology review. So it's not perhaps as robust as a double-blind randomized trial that completes its enrollment. Don't get me wrong, I'm involved, I'm a UK person, I'm really positive. But just before we overinterpret the results of this trial, those caveats are important. For me, it tells us one thing, or two things. The first is, I think immune checkpoint inhibition is active in kidney cancer. We kind of knew that already, but we have that signal for a second time in this disease, in the knowledge we've previously had negative trials for nivolumab, ipi-nivo, and atezo. So it supports the concept that these drugs are active in this space. That's the first thing. And the second thing, in the clear cell population, it doesn't give us any indication that CTLA-4 adds anything on top of PD-L1 inhibition.
Last question before we get Katie, you can get on stage, please. The study will have several years more follow-up, and let's say in the high-risk patient, a stratification factor, there will be an OS benefit. Will you use it? Yes, no. It's approved.
So is that just the durva-tremi arm and not the...
Right, durva-tremi. Will you use it over...
No, because I think it's easier to give pembrolizumab, and I think that it's...
So no.
The trial wasn't specifically powered for that population. I think the chance at the moment, if you look at the landmark OS, they're 96%, and as an investigator-initiated trial, we may, the budget's not huge, we may struggle with robust OS follow-up. So my interpretation of this at the moment, as it stands, is the trial would need to hit OS in the same way as 564 did before we start looking at subsets.
Fair. Katie, sorry. Okay. Go ahead. ASCO GU.
Well, I just want to say, having sat in the audience and now getting to help add to this totality of data, I mean, how amazing all of this research and just hearing it all in one session is so impactful. And so it's my pleasure to be here to review the GU ASCO 2026 highlights. And if you see me get pushed off the stage by Toni or Tom, I welcome any input as these two investigators have largely presented this data over the past year. So as you all, this room very well knows, the huge highlights at GU ASCO 2026 were the initial presentations of LITESPARK-011 and LITESPARK-022. And I'm thrilled again to be able to go through this data. When I reflected back, we're only 6 months into the year, but I almost feel a little bit like we've, as Brian mentioned yesterday, had this wonderful story over decades, understanding the biology of clear cell kidney cancer, now the ability to target it, then the approval of monotherapy in the refractory space. And I really feel like what 2026 has started to do is allow us to learn what is the best treatment location for HIF targeting, in what combinations and where in the therapeutic land space. And so I'll be highlighting the data that was presented in the adjuvant space as well as in the refractory space. And then Laurence has already mentioned, we've heard a press release that in the first line space that will be presented by Toni at ESMO this year. So again, I think this room knows better than most why we consider HIF2 important in kidney cancer and the challenges that have come both in understanding the biology as well as being able to target this. And then subsequently with the approval of the first HIF inhibitor, belzutifan, our ability now to manage a novel side effect profile for patients who benefit from this, which is clearly dependent on clear cell biology. And then this summer, actually in just the last few weeks, we've seen an FDA approval as well as a subsequent New England Journal of Medicine publication that have come from LITESPARK-022. And so with that, I want to start by highlighting the data that went on to achieve this, of course, wonderful response and FDA approval. And this is the initial reporting of the DFS data. On the top is the investigator-assessed response data showing an improvement with a hazard ratio of 0.72 that was confirmed by BICR, 0.76, calling out here that the absolute reduction in disease-free survival there was approximately 7%, that the curve separated early and stayed separated even after the 12 months of belzutifan was completed. You'll see, and just to draw attention, we'll continue as we see median follow-up here was 28 months and ongoing follow-up certainly to come in future presentations. In the BICR review, perhaps the absolute risk reduction might be trending slightly lower, starting also at 7% as the investigator assessment, but closer to about 3.8% at that 30-month mark. And then again, just to highlight and put this all in the context that we are comparing it to, this is our very first huge 1,800 patient randomized trial with an active control arm. So while we put it in the context of Keynote 564, I just encourage us all to keep in the back of our mind that Keynote 564 certainly, that all of that data was created comparing to placebo. And of course, we all eagerly try to understand who is it the patient that gets this great response and goes on to benefit from this combination therapy. And you can see in the DFS subset, it tended to favor that it was beneficial across all subsets. And subsets are not meant to be statistically designed to answer these questions, but just to, again, highlight in the Keynote 564 data, slightly different patient population up against a placebo, but the story was easier to sell when sometimes we would be saying, we don't know who's the right person to treat with this combination, but it appears in Keynote 564 like those subsets suggested the more aggressive, higher risk biology may have been the patients that benefited from pembrolizumab monotherapy. And in this combination of pembrolizumab and belzutifan, the story was a little less clear. You can see, again, a strong signal in that intermediate to high risk, and then less so. Again, numbers quite small and very difficult to estimate with these wide confidence intervals. But again, I'll highlight my enthusiasm for continued biomarker research and hopefully ability, whether it's MRD testing or actual HIF inhibitor signals that tell us which is the patient, hopefully that we can be most benefiting with this combination. And then Dr. Powles here presented nicely, and so I'm summarizing some of the data that has subsequently been presented, which I know is cheating, and I was only supposed to do GU ASCO 2026, but I couldn't help it. And so Dr. Powles presented at EAU some additional exploratory analysis that came from LIGHTSPARK-022, and again, suggesting that regardless of this aggressive variant of sarcomatoid biology, patients tended to do well in the combination arm as compared to pembro monotherapy, and that the next few lines are additional exploratory analysis, for example, DFS benefit after and metastasis exploratory endpoints there that showed additional benefit in the combination arm. And then the last slide here on LIGHTSPARK-022 that we also were reminded of yesterday is just that it's so early. Only a total of, I believe, 86 events have occurred at this median follow-up. And as a reminder for most people, it took 5 years when we saw that overall survival data come from Keynote 564. So we'll continue to watch as this trial matures. And then I won't spend much time because I think Dr. Powles did a wonderful job yesterday giving us the quality of life update that we saw from LIGHTSPARK-022, and also hit home that it's not only the quality of life questionnaires, but also what are the side effects that our patients are experiencing. Unfortunately, we do see that there is a doubling of the grade 3 adverse event rate. It's been pointed out, these adverse events are reversible. We recognize that they're often on-target anemia, hypoxia, these things that we can monitor for. And then, as was seen yesterday, while there were no significant difference in the quality of life, there may have been, while on therapy, some differences in the functional life domains, but those recovered after patients completed that year of adjuvant belzutifan. So I think my Monday morning message now in July 2026 is different than my Monday morning message was in February, because excitingly, the FDA has granted approval already for this combination therapy, that we've seen additional data, both exploratory analysis, now we've seen even quality of life data to help us understand. And I think, to me, it's just a question of trying to pick who's the right patient for this combination. And now, actually, such a benefit that we have 2 different regimens that we can choose from. A regimen such as pembrolizumab monotherapy that has clear DFS and OS benefit in the adjuvant setting, still again trying to understand biomarkers and MRD to pick which patients need any adjuvant therapy, and now seeing a clear DFS benefit with this combination treatment. So I think still to come, OS maturity, I hope, biomarker data, and then we have all said it in the past, and I will just emphasize it again. These are often the longest, hardest conversations to really talk through with a patient, to explain what exactly each of these benefits truly means in a patient's mind, and what are the risks, what are the side effects, how fast or will those side effects reverse in the case of IO-related AEs. And so with that, I'll transition to the next talk, and this was also, again, looking at HIF-alpha combination therapy, but here in that unmet need that Dr. McKay mentioned earlier in the refractory setting of RCC, this space where patients progress on PD-1, and the thing that we want most is for them to continue to have durable, quality time. And so here, just to give context, I've put several trials, some of these including Lincabo, just mentioned by Laurence, but I thought these particular trials gives us a nice overview for how we have continually been sequencing TKIs. So in Contact 03, a large randomized phase 3 showing a very commonly used cabozantinib monotherapy arm there with that PFS there of 10 months and objective response rate of 40%. In the Lincabo data, again, phase 2 study, but in that similar setting of second and third line refractory space, seeing a median PFS of lenvatinib and everolimus there at 15.7 months and an objective response rate also in the low 50s. And then I've highlighted here in the middle the challenges that we experience when we're trying to give belzutifan monotherapy alone. While we recognize, and so many of us have seen in clinic, the durability that a patient can have on monotherapy belzutifan, the worry in the back of, I think, all of our minds when we're starting a patient on this is the 1/3 of patients who unfortunately progress on that first or subsequent scan, and in such a refractory setting may be difficult to get additional successful therapies in. So this trial took patients who'd had prior PD-1 or PD-L1 failure and randomized patients to receive lenvatinib at 20 milligrams with belzutifan 120 milligrams daily versus full dose cabozantinib at 60 milligrams daily, with a primary endpoint you can see here of PFS and OS, and I look forward to seeing that final OS data come out at ESMO this upcoming year. That's exciting. Just to give you a background and emphasis here on the baseline patient population that was included in this trial, again, what you're seeing here is the majority of these patients did only have one prior line of therapy. So 2/3 of patients, this was their second therapy after progression on that PD-1. And then to emphasize, almost 43% of patients had had no prior TKI, so came into this trial being TKI naive. And so in that setting, we saw this improvement in PFS, again showing approximately 14 versus 10-month change in PFS when we look at lenvatinib plus belzutifan versus cabozantinib monotherapy, an objective response rate there that was 54% versus 40% in the combination of lenvatinib plus belzutifan versus cabozantinib. And the things caught my attention, I should say, is that these curves, I think, are quite similar to the curves we have seen in other HIF studies. For example, at the beginning of these curves, you can see that they overlap. And in my mind's eye, this suggests that perhaps those patients who had a more aggressive disease biology and were perhaps unfortunately not responding coming off the curves, it was somewhat equivalent, the various mechanisms or TKIs. But where you see those curves at about 6 months start to separate, those patients having benefit, having clinical benefit, then what we see and what we all hope is to have that durable tail of the curve that we have seen with prior HIF studies. And so here, I've kind of put all of these trials together just as a nice summary slide and highlighted in red what is, to me, most clinically impactful for my patients. Again, previously having sequencing of TKIs and then seeing this doubling of a durable response from approximately 12 months with a single agent TKI to about 23, 24 months there with lenvatinib and belzutifan. And I think this is what many of us are very excited about. So the toxicity and patient experience in a refractory setting where we may not be curing more patients, although we also always aim to, but in that setting, if we're adding additional drugs, what is the toxicity experience like? And I think I got rave reviews about this AE profile for the tornado plot coming in, because if you are not close enough to the screen and you can't tell which regimen is which, without looking at the exact AE profile, actually these tornado plots look quite similar across the arms. Of course, if we delve down into it, we do see some eye-opening things that have changed my practice. And so as we've gotten anticipated excitement that lenvatinib and belzutifan, will be reviewed by the FDA this fall, I think the thing that has changed in my practice is making sure that I get a echo at baseline, making sure that's in our treatment regimen and on treatment, because we did see some increased cardiac monitoring that was necessary. And then otherwise, I think, again, the different side effect profile that we expect, but anemia and hypoxia, again, appreciated Dr. McKay's points and her, great publication that will come out to just really help the community understand how do we support patients who are on these therapies, and how can we best make sure that they're able to stay on this treatment. And also, there was quality of life data presented for this initially, even at the GU ASCO talk, the very first presentation, showing that there was no difference in the quality of life, time to detriment in LITESPARK-011. So in summary, and I think I'm right on time here, again, very exciting in the adjuvant setting. We now have 2 options here with FDA approval, both with DFS, Pembro certainly still with OS, and we look forward to seeing maturity of LITESPARK-022. And then subsequently in a post-PD-1 setting, I think we're hopeful that we'll see an FDA positive review of that data. Again, a final OS signal to come at ESMO. And I think just so many great options and so much great science has really come about in kidney cancer over the last year. So an honor to be here and to discuss the data.
Excellent.
Okay, so we got some questions from the audience. I'm going to start, if I may. Laurence, I've sat through quite a few presentations with TIGIT and LAG-3 now, maybe a dozen, maybe more, in this disease, and they're always negative, and yet we sit in audiences like this, and the conclusion always seems to be we need to do more studies. Have we today reached the point where we need to say, the TIGIT and LAG-3, we've looked at this enough, it's time to do something different that might work?
So I think it makes sense. We want to explore new targets and want to make the most of each of them, so properly explore them. If you think about the table where we plotted all the arms of the umbrella study, I think the decision to go on a large phase 3 is an important one, and you want to be on the safe side, especially given we have so good data now in front line. So ultimately, you want to make sure that you have high response rate, long PFS, because that's going to be your primary endpoint, and ultimately you want to reach for overall survival. And what we are seeing as of now may not be ticking all the boxes. So to go on a large phase 3 frontline, my short answer would be no. Does that mean that we need to reject LAG-3, or does that mean that we don't yet have a good biomarker to select? But I understand the decision of not taking that arm to a massive phase 3.
So I totally agree with you. I want to say today I won't, period. I think when you have a new LAG-3, new TIGIT, unless the difference and some preliminary data are way better, I wouldn't. But I mean, that's me. What happens also, you forget, Tom, that sometimes in renal we're ahead, sometimes we're behind. If the TIGIT trial come, we're in the middle of a trial, starting trial, and the TIGIT or the LAG-3 in lung cancer, gastric came, are negative, the enthusiasm gonna wane. That's the other thing, problem with the field. Before going to Monty, I wanna congratulate Katie. I love her slides. She is one of the few that uses AI, what I call responsible AI, outstanding and moves to real slides, so love that. Monty?
Love this session. My question stems from Mike's presentation, but might be a more appropriate question for Katie, or I don't know if Scott Hake is here. I was just curious, Mike had mentioned the OPTIC trial, and I think we're all eagerly awaiting the Nivo-IPI cohort. My thought here is that, again, in the setting of a non-randomized study, if we don't really see an outstanding response rate in the Nivo-IPI cohort, then our whole premise of using this as a selection tool kind of falls apart a bit. So any updates on where that data stands at this point?
So I know we're very close.
Okay.
I don't have any additional updates, but I
Fair.
will.
Got it. Thanks.
Any question?
I have actually a question for Hans. I was intrigued to see that CPS enriched for benefit in the non-clear cell in the chromophobe, and I know your study PD-1 in the frontline setting in the CARE-1. Could you talk us through, obviously, the design, why you chose PD-1, and then in OPTIC you highlighted that site of disease was important. Are you delineating what site needs to be biopsied on that study?
Thank you, Michael. So as of now in Europe, we have the CARE-1 head-to-head comparison of IO versus IO-TKI that is now open in 11 countries. Germany just started, and we are enrolling our 500 patient this month, so we're very excited. This study used PDL1 staining, tumor cell staining 1%, because the data we had from the 214 trial, as well as what we had also in adjuvant 914 trial, suggested that there is an enrichment for response to nivolumab, ipilimumab in the patients that are PD-L1 positive. And so the hypothesis is that in PD-L1 positive patient, nivolumab, ipilimumab would be better than IO-TKI, and choice of the investigator could be Len, Pembro, Axi, Pembro, or Cabo-Nivo, depending on the choice of the investigator. So the rationale is based on what we knew from the 214 trial, as well as the 914 overall survival favoring IO-IO. Now, with regard to non-clear cell, they are not enrolled in CARE-1 because it's a pragmatic clinical trial. It's funded by EU, okay, so special funding, the Mission Cancer EU funding, and so we have to use the drugs within their label. And Nivo-IPI in Europe is not reimbursed for non-clear cell. So we cannot have the chromophobe. That would have been a good question.
And site of biopsy?
Yeah, so that one, I wasn't happy when I saw the OPTIC data because, oh man, do I have to amend the study? So it's likely there are differences between the primary and the metastatic sites. CARE-1 is a pragmatic trial, so the idea is not to ask for a second biopsy. So we do communicate towards sites saying, please try to biopsy a metastatic site rather than the primary. And what is intriguing in CARE-1 for now is that we have a high level of PD-L1 positivity. So once again, TPS, higher than what we saw in 214. Is it because this is a pragmatic patient population, so all comers, intermediate and poor, no good risk, for the same reasons of reimbursement? And so is it because those patients may not have been eligible for, like Cosmic 313 or 214 because some of them have highly symptomatic disease? We're seeing a high level of PD-L1 positivity, and that's very different from the registration study and even, I believe, from Pedigree.
I just wanted to add, yours really great work on CARE-1. I think it'll really help us understand the use of PD-L1 for kidney cancers. But for OPTIC, that high response rate in the angio clusters for Cabo-Nivo, I think was a really nice signal, even though it wasn't randomized. And to answer Monty's question earlier, speaking on behalf of Scott and Brian and the OPTIC investigators, I think we're still trying to find enough patients with those IO phenotype that to enroll for the Ipi-Nivo cohort, but it's close. I wouldn't be surprised if it finishes that cohort within the year, and I believe that there's another version that's coming of OPTIC, so stay tuned.
Hans, then I have a question. Yeah.
So optics showed very nicely that you should biopsy not the primary. You need to biopsy the metastatic disease. And we also now have seen numerous neoadjuvant studies where these tumors don't melt away with whatever we do, right? So it's very different than melanoma, lung cancer, etc. Where are we going with this, the neoadjuvant space? Is it something we should still pursue? Because the primary does not seem to reliably reflect the metastatic disease anyways.
To me, that's another aspect, hence, is how do we need to handle the primary? I grew up in the Carmina space, okay? So I'm a believer that we should first treat systemic disease. So we should start with systemic treatment and have basically systemic treatment to slow the pace of the disease and use response. And in those that are responder, then handle the primary. So to my perspective...
Yeah, that was not my question. It's really more, we're doing all these neoadjuvant trials now to maybe inform how we treat kidney cancer. And what I'm afraid of is that the primary tumor may not really allow us to really study that really well, because the metastatic disease is different than the primary tumor. In fact, you may not even finding well the clones that are the metastatic disease. There's a discordance between the two. In fact, I don't care what the primary tumor does when I give systemic immunotherapy. I cut it out anyways. So that's my question.
I respond to it. First of all, we do not do neoadjuvant study, and yes, we should have done, and I think we will on our way to do, finally, like other tumors, so that we can go to a general conference oncology and not be made fun of by the melanoma, lung cancer, breast cancer doc. We hopefully will launch the first phase 3 trial neoadjuvant to answer the question, not to answer how to do the neoadjuvant study, to answer the neoadjuvant approach is important, irrespective whether we achieve pathologic CR or not. The goal here, we kill enough tumor, one. Second, we sensitize these tumor more to, after surgery to adjuvant. And 3, and most important, patients are healthy enough, then they can go surgery, etc. Not that after surgery they cannot get therapy. So we need to do at least one. Second, I do not agree with optic or HCRN on primary versus metastasis, that different. We have not looked at them like that. We have looked at many other, from all the studies that phase 3 that we've run, including axitinib, cabo-nivo, nivo-ipi, David Brown, large cohort when he was here. We have not found difference between the primary and the metastasis. We have not in our program. So these 2 smaller studies that show some difference and make everyone believe that they're different and you need a biopsy in settings that are 10 times more patient in primary and metastatic that are frontline. So that these patients don't have, this is not an old primary, we have not seen it. But people don't talk about them because they're negative. We haven't seen them. David, from the study. So I think it's fine. Where I think the problem is going to be, if this is stage 1 RCC, then you have metastatic RCC 5 years later.
I mean, Toni, my take on that is I would be anxious at this point if the renal cancer community felt the metastatic biopsy sample is the answer to all of our questions. I don't think we've shown that in the trials. It may be, but I haven't seen data that shows that's conclusively the case. And I would be anxious if hospitals in Spain and the UK start taking metastatic biopsies with the 6-week delay associated with that to get tissue for a biomarker.
Actually, I have an idea for a junior person, just came up, of course I can do it. We're going to get all our data together, including optic, everything, and all the phase 3, and we're going to do a meta-analysis of primary versus metastatic and see if there is anything different. And hopefully that will answer the question. I'm not saying what you found, Katie, is wrong, etc., but it's asking a question and paralyzing us to do that.
Can I add just
yes,
some thoughts?
yes.
So I think this is just such a challenging question that the field has faced for so many years. Perhaps if we did multi-sampling throughout the entire primary tumor, we would actually find all of the heterogeneous clones that we then find in our metastasis. And also the challenge that even we saw in our very small numbers, to Tony's point, is that you can also biopsy on the off chance that a patient had 2 metastatic sites. Those can be slightly different clones as well. So I think it's the challenge that we have all seen and discussed and
So if
had
I
for
could
years.
just add before we go to Rena, absolutely agree. You know, even if there are some differences and we're seeing these clones emerge in metastatic disease, it doesn't negate trying to fight for cures in the localized disease setting. And there are these gigantic tumors, and there are locally invasive tumors that we absolutely need better neoadjuvant approaches. The best surgeon in the world is not going to clear that whole field. And I'm sorry, but we need to get to a neoadjuvant approach so that we can drive down those cures. So we, you know, I can't echo more. We absolutely need the next.
I think Hans, not to oversee, he's my best friend, but Hans' question is the past 15, 20 years, Hans, we've doing these phase 2, 30 patients to learn how to do the phase 3, and we have never launched a phase 3.
I mean, all the neoadjuvant data is abysmal in kidney cancer. I mean, response rate 20%. It doesn't reflect the disease. We are not making much progress there. And the problem is going to be we're just going to compound on the problem that we have with adjuvant therapy, that we overtreat. So now we're going to like treat like every of these little tumors with neoadjuvant therapy, with more complex therapy.
In the back row. Axel, come up here. Axel, come up here.
It's honestly what we're talking about is tumor heterogeneity, and there will be tumor heterogeneity. I mean, it's going. It's
very upset that the Dutch didn't
going.
It's. He's gonna take it on the German.
I mean,
go ahead.
No. Before, I just want to say, is Scott Ducote still in here? This is where we need to leverage the rapid autopsy series, and because we are not actually systematically sampling across the entire like spectrum of all of the metastatic sites. Like you're not going to be able to overcome heterogeneity, and in fact, probably when somebody only has a primary in place, the degree of heterogeneity is I suspect way lower.
That's why you look in the metastatic disease.
Anyway.
Okay, Axel. Okay, Hans, we're going to give Axel 2 seconds.
Hans, I think what you're forgetting is that in adjuvant therapy, we're also treating a lot of patients where we don't know whether they really receive or need therapy. And by starting neoadjuvant therapy, we can at least identify those who would need therapy and those who wouldn't. That is my.
If they just have a primary tumor.
Pardon?
So I mean, if you do neoadjuvant therapy with just the primary in place, you will overtreat so many patients where just the surgery would have done well.
Yeah, but we only do that for 6 weeks. And in adjuvant setting, we do that for a year.
6 weeks is really so it doesn't really stop the toxicity.
Well, I think the other thing you need to also understand is you treatment earlier. You start treatment earlier. So that's what we've seen in a lot of other randomized neoadjuvant studies. We know, for example, from randomized eligibility logs that about 15 to 20% of the patients between baseline and the 90-day eligibility check for adjuvant trials get a recurrence. And I do believe that provided your neoadjuvant therapy is effective, that you will see differences. We've seen that in melanoma, we've seen this in lung, we've seen this in bladder. So I think this is very important.
But I think my point is that that lung and melanoma is so different than kidney. We've struggled for years now to see something like what we see in neoadjuvant melanoma and lung. We don't see it.
Well, we do see. I think you're very critical, so... No, I mean, we're not seeing, I would agree, we're not seeing it to this degree as in melanoma, where you have 70% complete pathological response rates. But what we saw in ASCO, that we see after 6 weeks complete pathological responses in 10 centimeter tumors. I completely agree. What we do not know is which clone is escaping. So you might do something in your primary that doesn't hit the clone that ran away. But that is something to find out in a trial. So I wouldn't throw the child out with the bathwater right at the beginning.
And so the success in the other tumor types, in bladder cancer, in lung cancer, in other neoadjuvants where there's been great success, that success has not been based around biomarker-driven neoadjuvant therapy. These are also ITT trials that have been successful. I think it's true that we haven't answered this question. We are happy to answer the LAG-3 question 15 times. We seem somewhat reluctant to do a study in the neoadjuvant setting.
Correct. We only need one phase 3 trial.
That makes no sense to me.
One phase 3. Naomi was the first one to do a large randomized study for VEGF-TKI. Was negative, but then we did 5 others. So why we don't do one neoadjuvant phase 3 trial? Hence, I'm asking for one. Last question.
I just want to politely correct Rana, Toni, everybody. When you talk about neoadjuvant, can you say 12 weeks of neoadjuvant? Because Prosper was a neoadjuvant trial. It did not show a benefit, but please don't say Prosper didn't exist. Just say you're going to do 12 weeks, prolonged
12 weeks, 2 doses.
Going forward.
And I think we also saw what we learned from Prosper is in the recurrence-free survival arms, they both drop at the beginning. It's exactly this point. So some patients do not make it to surgery. They develop metastatic sites. So if you do an intention to treat analysis, I think you'd be surprised.
I think to speak to the point about duration, we actually don't know what the optimal duration. And NESIO was really unique in that it actually only looked at 6 weeks. So those pathologic responses emerge after a short period of neoadjuvant. So actually testing what's the appropriate duration? Is it 4 weeks? Is it 6 weeks? Is it 12 weeks?
But with immunotherapy, it's never 6 weeks. A single dose is 9 months.
Yeah, but,
it's never 6 weeks.
But the surgeon is telling us, many surgeons we love here, that look, 6 months, my blood pressure will go up, we can't, you have to do, so we're gonna do 3 months, which I think should be okay, not ideal, okay. Tom, do we end?
Tony's vacated his seat, so he no longer has control of the duration of this session. However, we have come to the end. I'd like to thank you all for taking part in this discussion.
It's break time now, so feel free to get up and stretch your legs.